Good afternoon. So thank you for the kind introduction and the kind invitation. I'm glad to be here. I was like thinking the same. I was like, the two diseases are combined together. Like I wish like we have options for our patients with CMML like CML, but maybe this will be a start. And all the patients always confuse CMML with CML, so they come to me with tons of literature about CML, and I say I wish. So having said that, I'll try to go through CMML in terms of diagnosis and treatment in general. So as you know, we're talking about like this group of diseases called MDS-MPN, and this is probably one of the least well-defined myeloid neoplasms by the WHO. It includes CMML, atypical CML, refractory anemia with ring sideroblast and thrombocytosis, which the name had been changed now to be called MDS-MPN with ring sideroblast and thrombocytosis. And then a group that's even less well-defined called MDS-MPN unclassified. And those diseases are heterogeneous both in clinical behavior and in their biology. So obviously in myelodysplasia, the hallmark of the diseases are the cytopenias and the resultant complications. In myeloproliferative diseases, it's usually the cytokine release and the splenomegaly constitutional symptoms. So the group of MDS-MPN combine those both features, clinically and biologically probably. They behave somewhere in between the myelodysplastic syndromes and the myeloproliferative neoplasms. And if you look at the genetic landscape of those, so the epigenetic mutations happen in the whole spectrum of chronic myeloid diseases. We see more splicing mutations in MDS, and we see more cytokine signaling mutations, or like the JAK2 mutations in patients with myeloproliferative diseases, and the MDS-MPN overlap share those mutations as well. So CMML is a chronic neoplastic stem cell disease. It's characterized obviously by the skewing or overproduction of monocytes. It has unique, genetic or systematic mutation occurrence and unique clinical features. So basically, those patients, could have either a dysplastic form of the disease or a proliferative form where there is leukocytosis. Peculiar presentations for those patients, different from MDS, includes the presence of the leukocytosis, splenomegaly, pleural effusion, lymphadenopathy occasionally. And unfortunately, they don't do even as well as MDS. So the outcome for those patients is even worse than MDS group. And there is no clear evidence that even some of the treatments that we use for MDS, like the hypomethylating agents, do alter the natural history of the disease in CMML. So in terms of their frequency, CMML probably is not that uncommon. The estimates are somewhere around 4 to 7 per 100,000. In my clinic, it seems to be like I see 1 or 2 per week, but that's very biased selection. But they are as common as probably essential thrombocythemia or polycythemia vera. So to diagnose CMML, one would require presence of persistent monocytosis, more than 1,000, and more than 10% of the differential. There are occasions where we see monocytosis more than 1,000, but that could be if the white blood cell count is high in any other disease, that the monocytes will be 1,000. So typically, it should be more than 10% of the differential as well. There should be obviously no Philadelphia chromosome abnormality, the blasts, and in this purpose, we add the promonocytes and the myeloblasts. They should be less than 20%. So in CMML, one doesn't require presence of dysplasia to make the diagnosis. So if there is persistent monocytosis, more than 1,000 and 10%, and one would demonstrate any evidence of clonal cytogenetics or molecular abnormalities, one can make the diagnosis of CMML. Now, monocytosis can be seen in other conditions. So you can see monocytosis in myeloproliferative diseases like myelofibrosis as well. So it sometimes becomes more difficult to tease out. And we talk about now in kind of joking about amonocytic or monocytic CMML, that patients don't have monocytes, but they still could have CMML. So what happens in CMML, obviously, is similar to many of the chronic myeloid neoplasms, that we originally get a somatic mutation at the stem cell level. Those could be some of the CHIP mutations that we know about. Then subsequently, we get other mutations, probably at the level of the common myeloid progenitors, that will lead to skewing of the production so that we get more monocytosis. And they render those cells to be very hypersensitive to GM-CSF. So Eric Padron in our group had demonstrated that similar to what have been seen in CMML. So he studied CMML and was able to show that patients with CMML have this high sensitivity for GM-CSF. And as we discussed, obviously, like the MDS or MDS MPNs and MPNs, the genomic landscape for those patients are variable. There is enrichment with mutations, particularly epigenetic and splicing mutations in CMML. But compared to MDS, I think it's a little bit more homogeneous in CMML in terms of the mutations, if that looks homogeneous. So, but we typically tend to see more epigenetic mutations like the TET2 mutations and splicing mutations. It's very rare or unheard of, for example, to see a p53 mutation in CMML unless patients are progressing to acute myeloid leukemia. And we tend to see like co-occurrence of mutations. So we see the TET2 and SRSF2 mutation. And in some studies suggested that the co-occurrence of the two mutations is very specific for patients with CMML. But at least we can identify an abnormality in almost 93% of the patients with CMML. Now, this is another thing that we've been using is like looking at flow cytometry to look at the types of the monocytes. This was originally pioneered by the French group, trying to look at what we call classical monocytes, which tend to be CD14 positive, CD16 negative. And it seems in patients with CMML, the monocytes are almost exclusively classical monocytes compared to other conditions. So we've looked at that also in our cohort of patients. We had age-matched controls and CMML patients, and we could demonstrate the same thing, that basically in those patients there is almost restriction in CMML to the classical monocytes that you don't see even when patients are on treatment, nor you do see in patients with, for example, AML or CMML with promonocytes. So it seems to be specific for patients with CMML. Obviously, it's not 100%, and it's not, but it could be a tool that helps in establishing diagnosis, especially in those cases where we are now saying that everything looks like CMML, but they don't make the cutoff of the 1,000 monocytes to make the diagnosis for CMML. So once we establish the diagnosis for those patients, as usual, we want to estimate the risk of the disease because we try to tailor the treatment based on that. And it gets even more confusing than MDS, that there are several models, risk models, to predict the responses or the outcome for patients with CMML. This is, again, work from an international collaboration where we had almost 1,800 patients with CMML, and we tried to look at several risk models. The bottom line that they all predict the outcome for those patients. So you could risk stratify patients by revised IPSS or the global MD Anderson model, but they all have their faults and shortcomings, and all the patients could have a little bit more heterogeneous behavior or worse outcome than predicted by those models. There are specific more models now developed for CMML that had incorporated some presence of somatic mutation. There is the French model and the Mayo Clinic group model, and they both incorporate clinical features such as leukocytosis, anemia, thrombocytopenia, and presence of somatic mutations. It seems that presence of ASXL1 somatic mutation had been shown by several groups to carry worse outcome in patients with CMML. And it may be important to recognize the type of the somatic mutations observed in ASXL1. So it seems that the frame shift and the nonsense mutations are the ones that matter in CMML, not so much for the missense mutations. So you could use any of those models, the GFM or the Mayo Clinic model, adding these somatic mutations into the equation of risk stratification for patients. And then there is the Spanish group also that have a model that incorporate the cytogenetics, presence of somatic mutations, not only the SSL1, but others such as RANX1 and SETBP1. And in addition to some of the clinical features, one would come for a better probably or refined risk stratification for those patients. So obviously, like in MDS and in MPNs, the therapeutic recommendations are based on risk. Obviously, the main consideration or the only therapeutic option for those patients always remains allogeneic stem cell transplant. So the question always in our mind, is the risk of the disease high enough to justify a risk of procedure such as allogeneic stem cell transplant? So I think the consensus still in patients that are at the age that they could be considered for allogeneic stem cell transplant with no major comorbidities, if the disease is higher risk, one would consider transplant. It's important to note that actually majority of the patients with CMML would be categorized as an intermediate or higher risk. It's really not common to see patients with very low risk with CMML. And in this kind of consensus or agreement by experts from the NCCN, they say that it seems to be that there is evidence of benefit if patients go to transplant while they are in remission in CMML prior to transplant. So allogeneic transplant in general, the cure rates are somewhere around 30 to 40% for patients with CMML. Those are different series. They're reporting their outcome. What predicts outcome is obviously what we have known in MDS as well, that patients that have higher risk disease will not do as well. Patients that have low performance status will not do as well. But in general, the cure rates are somewhere around 30 to 40% when we consider patients for allogeneic stem cell transplant. So we follow the same model like in MDS. If the patients are a higher risk, then obviously we are thinking that the benefit of transplant outweighs the risk. So the other option that we've used for patients are cytoreductive agents, namely Hydrea in the past. And most of the time we thought of it as a band-aid for patients' symptoms. So there is subtype of CMML patients that will present with dysplasia and cytopenias, and the major issue would be cytopenia, and those are treated like MDS. But there is also a group that will present predominantly with proliferative features. So those patients have constitutional symptoms, splenomegaly, leukocytosis. And we've typically treated those with Hydrea as we do with myeloproliferative diseases. So most of the time we've thought that the treatment is really just symptomatic, and it's used to reduce the disease burden or symptoms for those patients. We recently have tried to look at this, the impact of leukocytosis. Does it matter? Because we classically always said it doesn't matter what's the white blood cell count for those patients. We could observe them unless there is blast increase or transformation, that it's okay to have leukocytosis if patients are asymptomatic. But we've observed several patients in the clinic that when their white blood cell count is high, that we start to see some acute renal injuries and organ damage. So we tried to look at this in a retrospective fashion in our cohort of patients, looking at patients that have MPN CMML versus MDS CMML. And we observed that the rate of acute kidney injury, chronic kidney injuries, pleural effusions were much higher in patients with the proliferative type CMML. And when we looked at the correlation between the white blood cell count and the monocyte count, there was a clear correlation between the counts for those patients and the rate of acute kidney injuries, pleural effusions, and any end organ damage, actually. Then we tried to look at those in terms of quartiles, try to see is there really a threshold or cutoff where the white count goes higher, where we start seeing those events. And we tried to divide the patients in 4 quartiles, and it seems that you can see that the rate of those events does increase when the leukocytosis exceeds 34,000. So we started seeing higher rate of acute kidney injuries, pleural effusions, and end organ damage for those patients. So we also tried to look at the outcome for those patients based on leukocytosis. So this is the group that's proliferative. If the white count was more than 34,000, their outcome was inferior. Patients, obviously, if they had any acute kidney injury, their outcome was inferior. And then we looked at the question, did the Hydrea treatment make an impact? And it seems that those patients that were proliferative and received treatment with Hydrea did better, while we did not see that if they got Hydrea and their count was less than 34,000, we did not see any impact on the survival. So there may be a value for treating patients if they have leukocytosis to try to prevent end organ damage. Obviously, this is a retrospective review, but raises the question, should we just be observing those patients with leukocytosis, or should we consider treatment? I think in practice, I'm starting to consider some treatment for those patients, especially if I see the leukocytosis is progressive. So hypomethylating agents are probably the most widely used still for patients with CMML. The original studies that led to the approval of azacitidine or decitabine in MDS included only a handful of patients with CMML. So the impact is really not known. So all of those are retrospective reviews that tried to look at the hypomethylating agents used in CMML, showing that probably one would expect the same response rates in the range of 40 to 50% hematological improvement with either azacitidine or decitabine in CMML. However, they have not been shown really to be treatments that alter the natural history. We don't really know the impact of hypomethylating agents on survival in CMML. And when we try to look at variables that predict the outcome for those patients. So the proliferative type CMML, patients that have leukocytosis or splenomegaly, tend to do, unfortunately, worse with hypomethylating agents in terms of less responses and in terms also of worse outcome in general and worse overall survival. Whether decitabine or azacitidine is better treatment in CMML, it's really unclear. I think decitabine could sometimes be more myelosuppressive, so for patients that are proliferative, one could get a little bit more control of the counts. There was a retrospective review from MD Anderson trying to look at azacitidine versus decitabine, suggesting that the response rates, the CR rates, were a little bit higher with decitabine, but no difference in terms of overall survival. So as I mentioned, sometimes if those patients are proliferative and we are considering them for transplant, there is also some retrospective reviews suggesting that those patients that went into complete remission and proceeded to transplant did better. So I do favor using decitabine in that setting as a bridge to take patients to transplant. And then there are always, obviously, new response criteria, part of the international working group that they were proposed for patients with MDS-MPN, because historically, there had been only few studies done in MDS-MPN. So all the time, the responses were either based on the MDS response criteria or the MPN criteria that really do not capture the whole spectrum of the MDS-MPN. So those criteria are basically almost a hybrid between both, allowing to account for the cytopenia improvement, but also allowing to account for spleen responses, clinical benefits for patients, such as the ones that we see in myeloproliferative diseases with treatment. So in terms of what's coming for those patients or clinical trials that had been ongoing in the last couple of years, again, as I mentioned, this was work originally done by Eric Padron showing that those patients are hypersensitive to GM-CSF. So we tried a couple of approaches in terms of clinical trials targeting this pathway. One was using monoclonal antibodies to neutralize the GM-CSF. We've not seen much responses with that approach. The other approach was basically trying to target the JAK-STAT pathway, looking at JAK2 inhibitors in CMML. This is some preclinical work that Eric has done as well. And we translated that to a clinical trial within the MDS consortium that we conducted the first phase 1 and 2 of it, and now there is an expanded phase 2 that's gonna start soon, hopefully. So in the phase 1, we escalated the dose for patients from 5 milligrams to 20 milligrams, and then there was an expansion phase that had finished accrual through the consortium. We did observe responses in those patients. Interestingly, we observed hematological responses. There were 3 patients that had either bi- or trilineage hematological response in terms of erythroid, platelet, and neutrophil response. We had 1 patient with a bone marrow or marrow complete CR. And obviously, as expected, the most benefit for those patients will be in terms of symptoms and splenomegaly reduction. So around 46% of the patients had evidence of reduction in the spleen by physical exam. And when we looked at those new criteria, incorporating other clinical benefits such as patients' symptoms and fatigue, around 46% of the evaluable patients had responded. So this is moving forward more in the patients that are proliferative type of CMML to try to look at that. Interestingly, Eric had those PDX models that he's developed for the patients and tried to look at the responses. And we see almost 100% correlation between the PDX model responses and the clinical benefit that we've seen for the patients. And we tried to do this, obviously those are always biased, but tried to look at the, how did the historical cohort of those patients that had proliferative symptoms did, and how did those patients do on trial. It seems that there is some survival advantage for patients that were treated with ruxolitinib in the proliferative subtype, even when we adjusted for the risk of the disease or the timing from diagnosis for starting treatment. So in general, this is how I look at CMML. Obviously, we try to establish the diagnosis for CMML. As I mentioned, presence of monocytosis alone, if it's persistent, it could be adequate to make the diagnosis. You don't need the presence of dysplasia. We complement, obviously, the morphology by the molecular testing, looking at presence of somatic mutations. So if the patients have TET2, SRSF2 with monocytosis, that really probably increase the probability of the right diagnosis. We do also add the monocyte assay, looking for those cells that if they are classical monocytes. And once we establish diagnosis, we risk stratify the patients. Again, I think one could pick any model, probably the models that have incorporated somatic mutations, particularly the SXL1, do refine the risk stratification. If we define patients as a higher risk CMML, and the patients are eligible for transplant based on comorbidities, then we'll consider those patients for transplant. If they are proliferative, I do consider hypomethylating agent treatment for them prior to transplant. If patients are lower risk or they are not eligible for transplant, then the treatment is really based on the presentation for those patients. So if their presentation is more like MDS with cytopenias, probably the only option we have at this point are still hypomethylating agents to improve their cytopenias. If they are more proliferative, then obviously still hypomethylating agents could be a choice. Hydrea had been used, and now hopefully with the further clinical studies, we will be able to see if ruxolitinib will be a treatment that will be helpful for those patients. I think I will stop there, and I'll be happy to take any questions. I rarely finish in time. I have 37 seconds to talk. So.